Good evening, everybody. I would like to welcome you to our tonight's webinar, NoTube webinar, on the issue of tube weaning, tube management, and have the special pleasure of presenting our newly published book in the Springer Verlag, which I think has been already announced. And the book is called Child-Led Tube Management and Tube Weaning. And I'll start with a small introduction of myself, then tell you a little about the making of the book, which actually is a piece of work that took us nearly 5 years, and will then have the pleasure to also answer some of the questions which reached us. And just to start with, I have been requested by our technical team to ask you to not pose questions in the chat, but to use our Q&A section for asking any kind of question which you think about maybe while I'm talking, or you might have even prepared. And my team member, co-worker Eva Kashischnik will be answering these questions simultaneously while I'm speaking. So we hope to be as efficient as we can in the precious time we have together. So my name is Marguerite Dunitz-Scheer. I got interested in the phenomenon of tube feeding and using tubes in the early mid-80s, early 90s, when actually the first PEG G-tubes were being introduced into intensive care. We had had nasogastric tubes for about 1 century before in routine use on intensive care wards. And this introduction of these new devices really came into modern medicine a little bit like a flood. It was suddenly there, the same as extracorporeal membrane oxygenation, the ECMO. Once these things are invented, they somehow spread globally within 1 or 2 years, and suddenly all intensive care units and neonatal units and child surgical units were increasing the potential of frail and medically fragile children to survive critical times of operations or extreme prematurity by helping them with nutritional enteral support. And this really, really changed the landscape, because up to the mid-80s, children who were born with less than 1 kilo were more or less left to their own abilities of oral sucking, which they might have developed by the time of 28 weeks, but in many cases they were too ill and they would have died actually from malnutrition, because they wouldn't have been able to survive the critical weeks of respirator, need of lung breathing support and other medical interventions. So one was very enthusiastic about tubes, and very soon the market became flooded with a huge offer of different milk formulas, one better than the other. And well, the doctors and nurses and specialists who made the indication of needing a tube, which was actually in those days hardly ever shared even in consent with the parents. It was just decided, this child needs a tube, or it will profit from a tube in the next few months. Let's stick it in. So in the first few years, people were just using these tubes without being confronted in any kind of way with possible negative side effects. And it took quite 5 years for the realization that tube placement was a wonderful new invention, but that de facto it also had a few quite serious side effects. One of which was that the more you poured into tubes, the more vomiting, retching, and food refusal was the follow-up. And also that the amazing thing was found that only about 2/3 of all children actually thrived better when receiving more nutrients, but about 1/3 stayed in a state of malnutrition, even though they were getting enough calories, because their tolerance to manage the calories poured in was not developed and didn't exist. So in 1985, when I was just starting my training as a pediatrician, I somehow became aware of this new fashion which swept over the huge hospital I was working in and the neonatal care unit. And I also became aware of the nurses and the babies, especially in night shifts, who were struggling with these new tube devices. And it somehow seemed that there was a certain element of battle or of invasiveness, intrusiveness, that using the tube was not only perceived as being a positive support by the children themselves and also by the parents, but also had some serious side effects. And actually the first 2 or 3 children which we had referred to from other big hospitals in Austria was in 1985-86, and already in 1986 the first children from Germany, which had 10 times as many neonatal fragile children, started coming also to our ward in the University Hospital of Graz. And over the years, we were able, with the big support of our boss, to build up, it was called a SEDU, a special unit for severe eating disorders, which actually treated children with and without tubes with severe eating disorders from birth to young adulthood. And in this ward, which was very special because other wards were specialized for adolescents or for small children, we were able to gain enormous experience and also were able to really explore a new method, which we then in time started calling the Graz approach or the no-tube method, which was a kind of specific, we called it the psychosomatic approach. It was a strictly child-led approach, and it was a very, very individualized approach to help these children, which were being referred from all over Europe, get rid of the tube again. And now I'm just going to refer to one question, which was called, when is a child ready to wean? Because that is what actually was the crucial point. And the answer would be any child placed on a temporarily intended tube is ready to be weaned as soon as no more medical reasons needed to be kept on the tube. So if you have premature children, we try to wean them before their first discharge. So actually before their term birth date, the tube should really be out, and all efforts should be made during the neonatal intensive care to do non-oral and afterwards nutritive stimulation to help the child latch onto the bottle and the teat and the breast when tube feeds were being gently reduced. And older children who went through neonatal surgery, be this of esophagus, atresia, or diaphragmatic hernia, or cardiac interventions, actually should be off the tube between 6 and 12 months of age. And in Austria, we were well known enough, and our reputation was luckily good enough, that every single pediatrician in the country, when meeting a child, which was still on the tube by 12 months, in the case of the tube having been a temporarily intended tube, actually was sent to the Graz University Hospital to be weaned. So we had the incredible chance of having probably 150 to 200 children per year in huge groups, which we gathered together in a 3-week course, and somehow learned what was important on the child side, what was important on the parent support side, and how the hospital setting had to be changed to make something as natural as making a mess when eating a cookie be allowed to even happen, because normal intensive care units wouldn't actually dream of giving a child a chocolate bar or a cookie, because it would mess up the bed, and who would take care of that? So in those years, late 80s, early 90s, we invented the play picnics, and we were privileged enough to be given a very suitable large room without any technology in it, in which we had at that time one play picnic every day from 12 to 1, with a big group of 10 to 15 children and parents and doctors and therapists all gathering, and the children trying to keep the children in the focus of attention in the middle. Now, before I go into the questions, all this knowledge over the years poured into a huge amount of literature and studies, evidence-based studies, which were conducted and performed by a large team of researchers at the University Hospital of Graz. And about 50% of the literature up to 2015 on tubes worldwide was coming from our research group, because we just had the most numbers, having over 150 patients per year, while other centers were trying their luck with 1 or 2 or 3 children per year. Just gave us a very, very good archive of patients in practically every pediatric diagnostic subclassification group. So we had the cardiac children, we had the metabolic children, we had children with severe dysphagia, and we were able to study the specific differences, but also the joint similarities in the weaning process with these children. And in 2009, our hospital strategy changed, and probably for economic reasons, we were told that abroad referrals could only be done if the families paid for themselves privately, and the cost of the inpatient private treatment was about 3 times as much as what our courses cost now, because it was a big, big hospital and I had no influence on the price setting. So we actually then lost the international referrals, which was the majority, and they started pouring in emails of desperate parents asking for help. And after 1 or 2 years of trying to cope with this flood of emails without being able to archive the data on any kind of data protected platform, because I was only employed as a state doctor of the university hospital, we founded NoTube with the help of my son, who was going through a business study in Switzerland. And at the beginning, NoTube was a 1 woman, 1 student, and the webmaster firm. And in about 2013, the firm started growing. We started adding more and more and more therapists, because the numbers of people contacting us with the intention of receiving help in tube weaning was growing. And one day, a French father saying goodbye after an inpatient stay at the university hospital in 2013, mentioned that, asked us the question whether we would be prepared to come to France to wean some 20 children, which he would organize. And jokingly, we were saying goodbye to him, and the wean of his little daughter had gone very well and excellently. And jokingly, I said, okay, if you organize everything, then we'll come. And that's how actually our eating schools, more or less overnight, started as a model of a new kind of non-inpatient on-site treatment plan. Today we call this a day clinic approach. So the parents would either live in the same setting as we did, or they lived privately, but we would see all these children, and the first course had 20 families with 20 patients. We would see them from 8, 9 in the morning until 5, 6 in the evening, and spend 3 meals and many, many hours together, and groups and single sessions and garden sessions and running about and cooking sessions. And that's how our early eating schools in the years 13, 14, and 15 started. And we actually had 3 in France, 2 in Germany, Switzerland, Holland, and Austria. And after 3 years of traveling, we just got to the limit of our being able to cope with the amount of the referrals asking us to come to different countries, because all our private holiday time was being poured into this effort. And so we said we have to somehow change the venue, and made our first eating school in Graz, and the second eating school started then 2 years after. So the first one started in 2016, the second one in 2018, and that's this very beautiful old villa, which we are still in. The book was really an attempt to somehow try and grasp the complexity of the art of tube weaning into a textbook style. And if one is looking for, because we were training doctors and nurses and therapists all over the world for about a decade in conferences, in seminars, and actually found out that it wasn't the technical part of tube weaning which was the problem to be explained and to be understood. It was much more about explaining how to change an atmosphere within a team of people who were trained to look analytically and to look for mistakes and failure, and what giving them a kind of goal, what they had to do, to a much more child-led approach where you observe the child and try to focus on what the child itself has developed in skills, even though it has had the medical history, which in most cases has been a month-long experience on intensive care unit, and really, really, really critical times with many months of also respirator treatment, and oncologically ill children, and surgically children with 25, 30 operations in 2 years, and pretty extreme medical histories. But what we found out was the kind of common characteristic was that the inborn strive to learn to eat only started emerging and being observable after taking about 50% of the tube-fed volume down. Now, to do that after months of trying to value every single gained 20 or 30 grams, this appears to be really hard for parents. And of course, these medically fragile children have to be supervised on an absolutely daily basis. And this whole idea of trying to do something which seemed very easy, but to children who had really been exposed to intensive monitoring and counting of meals and medication needed to be given at certain times and completely externally controlled, to kind of make the turn from we are commanding the treatment path to we are trying to change the approach to let's observe the child and jump on the train the child has chosen to go. This is really what it's about. And this sounds easy, but it's actually quite hard for people with excellent training to step back from all they have learned and to become kind of respectful for a 2-year-old who is showing you the way the 2-year-old thinks that it could be done or it should be done. And so most of our work is observation, 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 and trying to find also ways how to help the parents support their child in a much, much less invasive way, not asking questions, not making suggestions, look, try and imitate this, and all this whole kind of business of I'll show you how to do it. That's not the way. And that's what this book is about. It covers the whole range from composition of tube-weaning teams to the diagnostic groups, which group of children have to be treated differently because of their underlying medical condition, up to the details of actually tube weaning and helping the parents also make this transition from being a controlling, counting, and active parent in the feeding interaction, whilst having a passively tolerating child at the best, if it was not vomiting all day long. This switch needs a lot of support for the parents. And in this book, whoever of you wants to try and read it, we tried very much to write it in a easy and, I would hope so, enjoyable style, with a lot of little vignettes demonstrating what we're trying to say, and on a pretty personal level. So it's not a typical textbook style for medical professions. It's addressed to parents, to therapists, to medical doctors, psychologists, and actually anybody who, even as a parent, wants to understand the philosophy behind the approach better. Now I've been talking for a long time. Shall I continue with the questions? Okay. Yeah. Okay. I hope you can hear me. So I'll just I'll read from the questions which were handed in. And the first question was, how do you guide a child from pureed food to solids? Now, this is actually a question which we should be answering a bit later. It's not specifically about tube feeding, but I just want to give a few words on it. The whole idea of guiding children is not right. These children, whether they are mentally compromised or even severely disabled or smart little toddlers, have an extreme will of their own. And the whole concept of showing your child something, helping your child, supporting your child, guiding your child, using tricks and deals must be abandoned. It's just not the way how to do it. And the whole idea of encouraging a child is actually absolutely counterproductive. So the first thing we have to explain to the parents, and this really takes a few days to digest, is stop trying to do something in the best of intention. Because the more the parents push and try and put expectation into the air, the less it's going to happen. Now, as long as children are fully tube fed, which is mostly the children are receiving 100 to 120 mils per kilo, as long as we are having a child on full tube feeds, forget about any kind of transition. Whether transitioning from tube to bottle, from tube to spoon, from puree to solid, it's not going to happen as long as the child is filled up to here. Because these children, as we perceive, have never ever experienced hunger. They're actually living between I'm full, I'm very full, I'm nauseatingly full. So taking down about half of the food, which has to be decided to be safe by the medical responsible of the weaning project, is the first step before you even can expect to see any kind of visible change. And this is very important because parents with the best of intention actually irritate their child with constant trying. And constant, the child gets 150 mils of anything poured into its stomach, is trying to digest this without the natural enzyme and hormone support, which happens when you eat orally and naturally. And basically, you are pushing the child into a dead-end road because you are offering new things in a situation where it's just trying to cope and survive. Now, the second question was that a mother is moving from Chile to Switzerland next spring and just asks how the technical way would go, how to get into our program. And that's very easy. I hope our new website is simple enough to show how the assessment process is started by a free evaluation, which I very much invite you to use. It is free, and it's actually done by the most specialist team members we have, who in a 20-minute talk and exchange, sometimes even being able to see the child, can very much get a sense of, could this be an option for you and your child? And after this free evaluation, you go through an assessment process which asks for uploading of 3 different videos of the child, showing a 1-minute sequence of a child in a feeding attempt, in a drinking attempt, and in a play situation, so that we get a feeling of the developmental level of the child. Then there's quite an extensive questionnaire to be filled out. And the third part is asking for recent medical reports in the children who have complex medical matters. If the child is a basically healthy child and has just gotten into a severe eating conflict, and the tube was placed because of reasons like infantile anorexia, we will of course understand that probably there are not so many medical reports. But you'd go through the free evaluation, then you go through assessment, and then 2 independent pediatricians will look over all these individual reports, which you have uploaded, and give you mostly within 24 hours, sometimes at the weekend, 48 hours, response on the suitability of your child, either for visiting one of our eating schools or for starting with the online method, which is called the net coaching. At the moment, we are currently offering 10 eating schools every single year in 10 months. So they're practically distributed over the whole year and last always 2 weeks. The children doing the net coaching are not time bound. The net coaching mostly can start within 1 or 2 days after assessment has been completed. And in cases when we need, for instance, in the case of dysphagia, specific examination findings, or additional reports, we will contact the parents and ask for that. But basically, since our eating schools are mostly booked out 1 or 2 months ahead, so if you decide now for an eating school, you'll be recruiting for December or for January. That one just has to know, whilst the net coaching can start immediately. So if parents are really desperate and the child is vomiting and really not in a good state anymore, then it is probably best to start in the net coaching. And if you have the possibility, depending on where you live, to visit the eating school, this usually turns out as a kind of life-changing event, because it's absolutely the contrary to any kind of inpatient or hospital-based, clinic-based situation which you and your child has ever experienced. It's a kind of, I would say, eating world holiday, or a transformation of a concept in which you have never dreamt to be finding yourself. From day one, the children just run in and, yes, are open to all the group things we offer. And in all these groups, the amazing thing is that we don't focus on how to get food into the mouth. We focus on how to get the mindset of child and parents onto a new approach in the contact with food. So they don't look at food with the feeling of, oh my God, will I vomit that again in 5 minutes? But they are very, very, very gently guided towards learning to want to touch food, to have licks at lollipops, to make games and toys with food. So the whole contact child food unfolds in a completely new level, where the end of the long line is at the end to put a piece of something into the child's mouth. The best is when the child does that itself. But the eating school experience can really only be grasped if you look at our videos, of which we have quite a few, and if you read the testimonials, because the parents are usually more shocked and more amazed than the children, because the children are open to really anything which is fun. They will try and engage in. Now, the third question I got was addressing the difficulties of tube weaning. What do you do with toddlers who have their own mind? And that's, I think, one of our absolute highlights. We are specialized on smart and stubborn toddlers. We love them, and we encourage them to find their way about in our eating school. They are allowed to have access to the big fridge containing very many goodies for children, which probably can't all be called classical healthy food. But in the first step, if you've never, ever, ever had any food in your mouth, we believe that the ideology of it has to be an apple or a vegetable first would crash our expectations to help the child. Because if it's something the child wants to have, the probability of it picking it, holding it, licking it, biting it, even swallowing it will, of course, be much bigger. The next question was, do you also help children with Down syndrome? And the answer is, of course. The Down syndrome group is probably nearly 10% of all our patients. And they're wonderful children. They're actually easy to wean. You just have to respect their very special, sweet, but very stubborn personality and their own pace in their development. So a 15-month-old child with Down syndrome will probably be at a slightly different developmental stage than a child without Down syndrome. and we just have to adjust to that. Yeah, we are always asked over and over again about this whole concept of hunger provocation and starvation programs. Especially the doctors in the Netherlands got quite obsessed with a program called the starvation provocation by Dr. Kinderman in the Amsterdam Children's Hospital. And unfortunately, it works in probably about 30% of the children. In the other amount of children, the trial has to be stopped, interrupted, because the children, if you give them no calories at all, they will just collapse, lose energy, lose motivation, and the situation can then very quickly become critical and medically irresponsible. So this is absolutely not what we do. We go gently within 2 or 3 days, including the ability of the parents to make the step of reduction from 100% to 50-60%, and observe the child very carefully in its oral change in these days. And some children just jump on the train, and the first day they drink 10, and the second day 50, and the third day they're drinking 200, and on the fourth or fifth day you can pull the tube out. And in others, especially very smart children who are very careful and a little bit mistrustful, this same process can take 3 weeks. So at the end of the eating school, our goal is not to have every single tube-fed child on zero, but to give them the chance of making the biggest possible step towards needing less tube feeds and using their mouth in a self-regulated way as much as possible. So since our program in the eating schools includes a 40-day aftercare program online, we are very, very, very happy that our success rate has bounced up to a steady 95-96%, because we have the time and can give the children the time each single child needs to maybe make a 2-week break with only night feeds if the weight situation seems critical, or to just take a little longer, or to go home on day 12 without a tube, but to be supported for another 1.5 months until also the family, the parents, are confident enough to accept that the tube actually does not have to be used anymore. And in the case of nasogastric tubes, can be finally removed. And in the case of jejunal or gastric tubes, can not be used anymore, at least not for food anymore. Our approach, talking about this hunger provocation, is that we find that this idea of also separating the children from their parents, which is a behavioral approach, is very unfair, unethical, wrong, and will not lead to success. We think that the participation of the parents in this transition is crucial. If the parents don't believe that their child will be able to succeed without and live and thrive without the tube, if the parents are not convinced that this is going to happen, the child will have a drawback and the tube will bounce back to full feeds again. So the parents in our program are crucially, importantly involved and included and integrated, as well as the siblings, and in some cases also grandparents coming, because we just believe that the child, that all the important attachment figures of the child should give utmost security for the child to be able to indulge in exploration. And any child obsessed with fears And separation anxiety is not going to make a developmental progress. So we strictly believe in an anti-behavioral approach, and that's what we call the child-led. The question, the next one, was a 22-month-old child with an NG tube who developed oral aversion and got stuck again. So the mother asked whether a PEG would solve that, and the answer is no. The PEG is only a solution in children who cannot be given a nasogastric tube, for instance, atrasias, or children with nasal choanal atrasias, where there's no technical possibility to place a nasogastric tube, and for children where the medical complexity demands nutritional support for more than 6 months. I think in such cases, it's beneficial to go for a primary PEG, but a PEG is never an educational solution for a child which got stuck on an NG tube. The answer for a child who got stuck on an NG tube is to wean it and not to make the next irreversible step. I hope that's somehow clear. Yes, we also have a question concerning whether local physicians, dietitians, and therapists can be included in the work we are doing on a child. The answer is gladly and yes. Any person who the parents wish to be included and share their password with can be part of this journey, which is on the one hand very educational for the therapists, and on the other hand also ensures that the aftercare after the NoTube experience has finished will be continued in the same approach and mindset. And I find this very, very helpful. And whether this is an accompanying dietitian or accompanying speech therapist or pediatrician or nephrologist or any specialist which the child might need or the parents might wish to be integrated, it's always an advantage. What are good parent resources in tube weaning? How can one get GI doctors and medical teams more on board with the decision for weaning? Well, that's a very good question, because I think that in the most cases, this is hardly possible, because the most physicians don't even know what tube weaning is about, that tube weaning is possible, and that the idea of the intention of tube weaning might be a good one for this child. So one has to be very patient with your local teams, who might be absolutely excellent pediatricians and child surgeons, but not at the same time be knowledgeable about the concept of helping a child make this developmental step. Now, the next question says, my child is medically cleared to be fed by mouth, and how can you get her to hunger and to start having an appetite? And the answer is, we have to start weaning, we have to start reducing the tube feeds. And what we offer is to do this under very experienced and daily medical supervision and accompaniment with very, very good results. Now, Dr. Scheer has just joined us, luckily. So would you like to still say a few words about the book? We can't hear you. No. I don't know if we can change it. Little question. Now it's good. Would you like to say a few words to the recently published book in the Springer?
Yes, I think it was a quite good book, and it's feasible for interested parents as well as for professionals. And I duly recommend it. It was first made by you and then augmented and corrected by me. And I think it's a good book, and it's possible also to have only parts of it if you want to download it, which is possible anyhow.
Thank you. Very good. I will then go back to the list of questions because the next question was very interesting. What would you suggest when starting the procedure to prepare a child for oral feeding? Now, the question whether you start with a bottle or with a spoon or with puree or with solids depends absolutely on not only the age of the child, but specifically on the developmental stage the child is in. If you have a child which is able to walk and sit in a stable position and move its hands freely and get it interesting in a kind of picnic situation, the child might leap directly from fully tube fed onto solids. This might be possible in maybe children around 1.5, 2 years old, who will start eating crackers and wanting to hold a chicken leg or a lamb chop or suck on any kind of solid bread. And if you force that child to start on thin liquids and force it to try and indulge interest in a bottle, it'll probably do more harm than good. So there's no answer for this question depending on only age. It is always depending on the character and specifically on the developmental stage of the individual child. And also of the family situation, because if you're weaning a first and only child living only with adults, the environment will be different as weaning a twin or triplet child in a whole group of children, where we might have children models 2 years older being very, very helpful. I think we're going to lose Dr. Scheer again right now. Okay. Okay, I'll jump to the... If your child gives hunger cues but still refuses to take large volumes by mouth, will weaning be successful? Absolutely, yes. We have a saying that any child able to drink or eat more than 50 mils of anything will be able to wean. So we don't need the child to prove that it will manage 600, 800 mils in 24 hours before we reduce the tube feeds. This is absolutely improbable. But if a child can manage more than 50 in one portion, we are absolutely sure that the weaning process will be successful. How to find the right professionals to get the child from its tube feeding and off the NGT? This is a very delicate question because on the one hand, I don't want to hurt the feelings of any kind of colleagues who might try very hard to help children get off their tubes. Our experience has been that a single professional is practically impossible to make him or her let it happen as a single one, because either you are a single pediatrician or a single dietitian or a single speech language therapist. In all cases, you will not be able to cover what we call the whole bigger picture, which has to be tackled. You will always need to have at least 2, if not 3 people be involved in a therapeutic way, because we have to have the medical situation covered, we have to have the nutritional situation covered, and we have to have the developmental and practical situation covered. And it is very improbable that one single professional can offer that in one person. So you will have to be in the search of what we call feeding team. Quite 2 chapters of the book are concerned with how to choose the right feeding team and how to compose a feeding team to be sufficient in a diversified way. And most hospitals just don't have feeding teams. In most hospitals, the solution for children who have gotten stuck on their temporary tube feeds is visit the psychologist or go and see the dietitian or have the speech language therapist do some exercises. And in all these situations, it's highly improbable that weaning is going to happen because we just focus on too specific a side of the whole problem and are not addressing the child in its whole capacity as an active participant in the process itself. Is the method for everyone? Well, the method is for everyone placed on a temporary intended tube. If a tube was given for life support, then the method is not right. So any child given a tube where the parents are told, well, we'll use it for 3 to 6 months and then we'll see how things go, or we want to reach a certain weight goal, but it's not going to be a lifelong solution. Any temporary intended tube will be able to fit into our weaning problem and program, and specifically the only single medical problem which has to be excluded are the children with severe dysphagia and high risk of aspiration. In those children, we have a special, even more thorough assessment process because we have to be very, very cautious to share the findings of the colleagues who have been involved in swallow diagnostics and swallow procedures and assessment. And also in the case of children with very rare metabolic diseases, needing very specific diet plans and not being allowed to indulge in what we call a general normal toddler's diet. These are the 2 groups which need a more intensive look at and might possibly need to be excluded. When is the best time to start weaning? Well, if we can choose before 12 months, the best time is between 6 and 12 months, and the majority and average of the children who come to our eating schools is actually around 2, whilst the children who enter the net coaching online program, the average is about 1.5. So there is a slight difference, but basically the answer is as soon as possible, as soon as there's no distinct medical reason to keep the child on the tube any longer. Can a child with severe oral aversion successfully complete the NoTube program? Of course. These are exactly the children whom we are looking for, because oral aversion is not an illness. Oral aversion is a reaction. And it's not a diagnosis in itself. It's the answer of a pretty smart, sensitive child to an aversive feeding situation. And they just make the decision, well, then I won't be interested in food. But those are exactly the patients our method is very specifically apt for. How can we encourage more fluids? And these are the questions we really have to discuss with parents on a very individual level, because the answer how much fluids a child will need during the wean and after the wean depends very specifically on age, on size, growth data, medical diagnosis, and the composition of the oral diet the child has chosen to wean itself onto. So if a child weans onto only solids, we will need a little more water, fluid supplementation. And if a child weans onto puddings and custard and purees, then the so-called free drunk water will not be so necessary or crucial. Now I'm actually coming to the end of our time. Is there still any question I could answer for you? Please use our Q&A. You will also find the link of our new book in the chat written, and of course we would be really happy to encourage you to buy it, because I think it's really nicely written, and we're quite proud of having accomplished this long project, because to finish a book is much harder than to start it. And I very much hope that you had a good time, that I tried to cover questions which interest you. And please feel free to use our email to just ask any kind of question concerning your child or a patient. We are a large enough team to really be able to take the time for questions which are still needing to be clarified even before the weaning process starts. And don't feel shy about that. This is our job. We work in 3 languages, English, French, and German, and Italian and Spanish, if necessary, can also be offered. Okay, then I'll say goodbye. It was a great pleasure doing this webinar this evening with you. And we hope to see some of the children who might be able to profit from the NoTube method. Thank you so much for your attention, and bye-bye.